Hi, I'm Dr. Jack West, medical oncologist from Swedish Cancer Institute in Seattle, Washington, and I'm also the founder and president of GRACE, Global Resource for Advancing Cancer Education. And I'm happy to be here for a post-ASCO 2017 update with two of my colleagues. With me is Dr. Matt Gubens, who is Associate Professor in Medical Oncology, Specialist in Thoracic Oncology at the University of California, San Francisco, and Dr. Jyoti Patel, who is Professor in Medical Oncology at the University of Chicago, in Chicago. Thanks for joining us.
Thank you.
Thanks for having us.
Let's turn to small cell lung cancer. It's about 12 to 15% of the cancers we see. It's more associated with smoking and very rarely driver mutations, but it's also been a tough area because we haven't had a lot of advances. Immunotherapy has been tested here, as in so many other areas, and generally as a second-line treatment, and a few studies have come out looking at checkpoint inhibitors like Keytruda or Opdivo, and another important one of Opdivo with Yervoy as a two-drug combination in patients who have already gotten chemotherapy for first line. The most excitement, I would say, has been around Opdivo with or without Yervoy, and a question of whether the better efficacy of a two-drug combination is enough to justify the greater toxicity risk. Matt, what do you think of this setting, and how would you approach that, given that there is now an approval, it's in the guidelines now, included as an option. It's not FDA approved, but it's in the National Comprehensive Cancer Network guidelines as something to consider in previously treated patients.
This is a tough area. We've talked a lot about immunotherapy, where there's a lot of data coming, and we have to work with the data we have now. Small cell lung cancer, we've always kind of thought, because it's so smoking associated, that there was a better chance than not that immunotherapy would play a role as it does in non-small cell lung cancer. So these studies have been very, very highly anticipated. These are still small studies though, and the first reports we got last year were where patients went on either the Opdivo or the Opdivo plus the Yervoy without a random assignment, which is how we kind of control for a lot of other random things that can affect how well the study goes. And what that study showed was that even in patients who had already had chemo and progressed on chemo, for whom there's not great options right now, we saw about 10% of the patients who got Opdivo have a nice response, often quite durable, and about 20% of the patients who got the combination. And that was very provocative, and it led some of folks to start using that recipe, even though it's not yet FDA approved. And that's been controversial. What we saw at this meeting was the very first glimpse of some of the randomized data to look at patients who weren't chosen, their regimen wasn't chosen by their doctor, it was chosen by lottery, if you will. And it shows, just in a very early sense, it seems that the response rates and the benefits are about the same. We're still waiting for more data, of course, but I think it does, at least puts it on the table as an option. I'd still prefer a trial for a patient, but if I can't get access to a trial, and these are patients often, unfortunately, whose tumors grow quite quickly, and so they don't have the 2 to 4 weeks it takes to get situated on a trial, get signed up for the trial, get qualified, and get started. I like having this option, but I admit that what we're really concerned about is, as Opdivo is typically very easy in non-small cell and small cell, the combination has shown that some people really have significant side effects, and it seems that those side effects are higher in small cell lung cancer patients than non-small cell, maybe because there's already an immune component to their disease. We know that small cell lung cancer patients already have more likely what we call paraneoplastic syndromes, or things where their body's reacting against something the tumor's producing. And so there's a sense that maybe those are acting up more when we really stoke the immune system. So I think it's with a lot of caution, but it's also provocative enough that for the right patient, I do talk about either Opdivo or Opdivo plus.
Where does it fit in for you? How do you approach this subject?
So certainly small cell lung cancer should be a cancer that immunotherapy is effective in, right? As we imagine there are a lot of carcinogens, we imagine it's got a big tumor mutational load, it should be the ideal candidate. Unfortunately, we've seen response rates in about 20 to 25% of patients similar to other tumors. So it's not that it's the answer, right? But But for some patients, it's a really meaningful answer. And so my practice, again, is adopting some of the early, very limited data we've seen. At this ASCO, we saw early efficacy data, but it was more reassurance than anything. It was a little peek at, okay, something that this is likely safe enough in the short term. And so I and many others have adopted these drugs without full knowledge of how effective they are, how much they really modulate the cancer course, what the overall survival, and what the late toxicity is going to look like. And that's simply because it's an area in which, there's been a big unmet need for some time. And so I discuss with patients, assess performance status, we talk about toxicities, but in the absence of a clinical trial, it very much has come into our toolbox as a therapy for our patients.